Hello everyone. Today's topic is on allergy or hypersensitivity. As I mentioned in the previous presentation, our immune system is regularly fighting against invaders. It is a constant battle between the good and the evil. When our immune system attacks our own body, we call it autoimmunity. Our immune system turns against our own cells, destroying and causing damage to our cells. This happens when our immune cells fail to recognize our own cells and treat them like foreign invaders. Our immune system reacts to foreign invaders by trying to eliminate them. Hypersensitivity is when our immune system overreacts to a non-life-threatening foreign body, which normally does not cause destruction of our own cells. When a life-threatening invader enters our own body, it is critical to trigger immune reaction and eliminate or neutralize the invaders. However, what will happen if our immune system overreacts? We want to use just the right amount of weapon or method to eliminate or neutralize the invader. You never want to overdo it. You don't want to use a machine gun to kill a fly. Or you don't need to get a tiger to get rid of a mouse. When you overdo it, then you will end up with a mess like this. So today, I will talk about hypersensitivity reactions, which are conventionally grouped into 4 types according to the effector mechanisms that produce this reaction. Type 1 hypersensitivity reactions result from the binding of antigen to antigen-specific IgE, bound to its Fc receptor principally on mast cells. This interaction causes the degranulation of mast cells and the release of inflammatory mediators. Type 1 reactions are commonly caused by inhaled particulate antigens, of which plant pollens are good examples. Type 1 reactions have effects of varying severity, ranging from a runny nose to breathing difficulties and even death by systemic anaphylaxis. So here, immune reactant will be IgE, which is bind to a mast cell reacting with soluble antigen. Type 1 reactions have effects of varying severity, ranging from a runny nose to breathing difficulties and even death by systemic anaphylaxis. Type 1 reactions are commonly caused by inhaled particulate antigens, of which plant pollens are good examples. In Japan, 1 in 5 or even more people are thought to have pollen allergy of Japanese cedar. It is one of the most common trees found in Japan and releasing tremendous amount of pollen every spring. Spring is one of the most beautiful seasons in Japan, and it is definitely my favorite season. Cold winter is over and days are warmer and longer, and streets will be covered by beautiful cherry blossoms. The only downside being pollen allergy that I have. Eyes are always itchy, sneezing, and runny nose all the time. And this is what pollen looks like under electron microscope. Just by looking at these will make my eyes itch and make me want to sneeze. So what exactly happened in type 1 hypersensitivity? When a person first encounters antigen, your immune system creates IgE antibodies specific to these antigens. After the initial encounter and eliminating these antigens, then the remaining antibodies remain in our body, but bind with Fc YRI on mast cells and basophils and activated eosinophils. All these cells have granules containing preformed inflammatory mediators. It is important to note that these reactions are different from B cells and T cells in a way that they immediately release these inflammatory mediators after antigen binding to these receptors. It does not require a phase of cell proliferation and differentiation. These cells are also capable of carrying a variety of IgEs, and it is not restricted to carrying receptors of a single specific antigen. These features combine to quicken and strengthen the response to any antigen which a person has been sensitized. These are thought to provide protection against parasites. But in the world we live, where we rarely interact with life-threatening parasites, these responses tend to be stimulated by contact with non-threatening substances in the environment. The name mast cell derives from the German word Mastzellen, meaning fattened or well-fed cells, which is how they appear under the microscope. Mast cell granules contain principally histamine, heparin, TNF-alpha, chondroitin sulfate, neutral proteases, and other degradative enzymes and inflammatory mediators. They can also synthesize and secrete other inflammatory mediators such as prostaglandins and leukotrienes. However, prominent among these chemicals is histamine, an amine derivative of the amino acid histidine. Acute allergic reactions involve histamine binding to the H1 receptor on nearby smooth muscle cells and on endothelial cells of blood vessels. Stimulation of the H1 receptor on endothelial cells induces vessels permeability and the entry of other cells and molecules into the allergen-containing tissue, causing inflammation. Smooth muscle cells are induced to contract on binding histamine, which constricts airways, for example, and histamine also acts on epithelial linings of mucosa to induce the increased secretion of mucus. All these actions produce different effects depending upon the tissue exposed to allergen. Sneezing, coughing, wheezing, vomiting, and diarrhea can all be induced in the course of an allergic reaction. Allergens most commonly enter the body by inhalation, triggering allergic rhinitis. This causes local edema leading to obstruction of the nasal airways and a nasal discharge of mucus that is rich in eosinophils. It can also affect the conjunctiva of the eyes, causing allergic conjunctivitis, causing itchiness, tears, and inflammation. Allergic asthma affects approximately 130 million people worldwide, causing chronic difficulties in breathing, such as shortness of breath and wheezing. It is triggered by allergens activating submucosal mast cells in the lower airways of the respiratory tract and causing bronchial constriction due to contraction of the smooth muscles surrounding the airway. Allergens that activate mast cells in the skin to release histamine cause raised itchy swelling called urticaria or hives. Activation of mast cells in deeper subcutaneous tissue leads to a similar but more diffuse swelling called angioedema. A more prolonged allergic response in the skin is observed in some atopic children called atopic dermatitis or eczema. This condition is characterized by an inflammatory response that causes a chronic and itching skin rash with associated skin eruptions and fluid discharge. Eczema frequently presents in families with a history of asthma and allergic rhinitis and is often associated with high IgE levels. Eosinophils are granulocytes whose granules contain arginine-rich basic proteins. Normally, only a minority of eosinophils are circulating in the blood. Most are resident in tissues, especially in the connective tissue, immediately underlying epithelia of the respiratory, GI, and urogenital tracts. Just like mast cells, it contains toxic molecules and inflammatory mediators. The normal function of these highly toxic molecules is to kill invading microorganisms and parasites directly. Unlike mast cell, eosinophils do not express FcεRI and do not bind IgE, and cannot therefore be induced to degranulate by antigen. However, once an inflammatory response is set in motion, cytokines and chemokines in the inflammatory site induce eosinophils to express FcεRI. The expression of Fc gamma receptors and complement receptors on the eosinophil surface also increases, facilitating the binding of eosinophils to pathogen surfaces coated with IgG and complement. Eosinophils are highly destructive when they are activated. The patients with hypereosinophilia can suffer damage to the endocardium of the heart and to nerves, leading to heart failure and neuropathy. In localized allergic reactions, mast cell degranulation and the activation of the Th2 cells cause the accumulation of activated eosinophils at the site. Their presence is characteristic of chronic allergic inflammation, such as chronic asthma. Now, basophils are granulocytes whose granules stain with basic dyes such as hematoxylin. They are similar to mast cell, but not identical. Development of these cells have more common features with eosinophil. Basophils are normally present in very low numbers in the circulation. Like eosinophils, basophils are recruited into the sites of allergic reactions, where they are activated to degranulate by antigen cross-linking the IgE bound to the FcεRI on the basophil cell surface. Mast cells, eosinophils, and basophils often act in concert. Mast cell degranulation initiates the inflammatory response, which then recruits eosinophils and basophils. Eosinophil degranulation releases major basic protein, which in turn causes the degranulation of mast cells and basophils. Shellfish allergy is very common type 1 hypersensitivity, and it may cause vomiting, diarrhea, pruritus, urticaria, and anaphylaxis. I love seafood, and this plate looks heavenly to me. But this is one deadly plate for anyone with shellfish allergy. Peanut is another food that may cause type 1 hypersensitivity. Whoops, sorry, this is the wrong peanuts. Well, this is commonly known to trigger systemic anaphylaxis, and a person known to have peanuts allergy should be very careful to avoid consumption. Initial sensitization occurs when the immune system is challenged with small quantities of antigen and when the cytokine interleukin-4 is present at the time that naive CD4 T cells are presented with antigen. Under these circumstances, CD4 T cells tend to make a Th2 response, which then produces more interleukin-4 and additional cytokines that stimulate B cells to switch their immunoglobulin isotype to IgE. Once started, an IgE response can be amplified through the participation of mast cells, basophils, and activated eosinophils. These cells can secrete interleukin-4 and express CD40 ligand like Th2 cells, and drive class switching and IgE production by B cells. These are common pathways in which people can get sensitized with pollen or cysteine protease derived from dermatophagoids pteronissimus. That's a big word. Whoops, sorry, this is a different photo again. And this is what it looks like. This is the major allergen responsible for more than 20% of the allergies in the human population of North America. Dried feces of the house dust mite, Dermatophagoids pteronissimus. In the Caucasian population of Europe and North America, up to 40% of people are more likely than the rest of the population to make IgE responses to common environmental antigens. Allergists call this predisposed state atopy, and they have higher levels of soluble IgE and circulating eosinophils than non-atopic people. Family studies indicate a genetic basis for atopy with an involvement of genes on chromosome 5 and 11. One way to test a person's sensitivity to allergens is to observe the reaction when small quantities of common allergens are inhaled or injected under skin, and observe the reaction. You will see initial immediate decrease in FEV1 or wheal and flare in the skin within a few minutes, which is caused by IgE-mediated mast cell degranulation in the skin or in the airways. Then it is followed by late phase reaction of longer duration FEV1 decrease or more widespread swelling of the skin. This is due to the leukotrienes and chemokines and cytokines synthesized by mast cells after IgE-mediated activation. When an allergen enters the bloodstream, it can cause widespread activation of the connective tissue mast cells associated with blood vessels. This causes a dangerous hypersensitivity reaction called systemic anaphylaxis. Disseminated mast cell activation causes both an increase in vascular permeability and a widespread constriction of smooth muscle. Fluid leaving the blood causes the blood pressure to drop drastically, a condition called anaphylactic shock, and the connective tissues to swell. Death is usually caused by asphyxiation due to constriction of the airways and swelling of the epiglottis. The most common cause of systemic anaphylaxis is allergy to penicillin and related antibiotics, which accounts for about 100 fatalities a year in the United States of America. Systemic anaphylaxis can be caused by medications, food, or venoms such as bee stings. In the USA, more than 160 deaths a year are the result of anaphylaxis, which is the most extreme overreaction of the body's defenses. Treatment with an injection of epinephrine will usually bring this reaction under control. It stimulates the reformation of tight junctions between endothelial cells, reducing their permeability, and prevents fluid loss from the blood, diminishing tissue swelling and raising blood pressure. We all come across varieties of possible antigens or peptides, but we still do not know exactly why we get allergic to some of them and not for others. Some attempts to deal with type 1 hypersensitivity are avoidance, antihistamine, and desensitization. it is not clear how our body decides what's an antigen and what is not. Allergies are a prevalent and increasing problem of humans in the richer countries in the world. So, that is a million-dollar question. In summary, type 1 hypersensitivity reactions are caused by protein allergens binding to IgE molecules and activating mast cells. The activated mast cells release a variety of chemical mediators that orchestrate a local state of inflammation. Smooth muscles constrict, blood vessels dilate, and eosinophils and basophils enter the affected area. The effects of IgE-mediated reactions vary with the route of allergen entry to the body and the tissue affected, from rhinitis, asthma, hives and urticaria, vomiting and diarrhea, and to the extreme, systemic anaphylaxis. Considering all the symptoms that we have discussed, Mr. Peanuts may be suffering from a severe peanut allergy. Okay, type 1 sensitivity was the longest portion of this presentation, and the rest will be relatively quick. Type 2 hypersensitivity reactions are caused by small molecules that bond covalently to cell surface components of human cells, producing modified structures that are perceived as foreign body by the immune system. The B-cell response to the new epitopes produces IgG, which, on binding to the modified cells, cause their destruction through complement activation and phagocytosis. The antibiotic penicillin is an example of a small reactive molecule that can induce a type 2 hypersensitivity reaction. Penicillin, quinidine, methyl-dopa, and carbamazepine, they all may bind to surface components of red blood cells or platelets and create new epitopes. These epitopes stimulate the formation of IgM and IgG antibodies that are specific for the conjugate of drug and cell surface component. Binding of antibodies to the drug conjugated cells activates complement by classical pathway, resulting in either cell lysis by the terminal complement components or receptor-mediated phagocytosis by macrophages in the spleen. These may result in anemia or thrombocytopenia. Well, I wish all the immune reactions were as simple as this engineering flowchart. Does it move? No. Should it? Yes. Lubricate. Does it move? Yes. Should it? No. Duct tape. Okay, now we will move on to type 3 hypersensitivity. Type 3 hypersensitivity reactions are due to small soluble immune complexes formed by soluble protein antigens binding to the IgG made against them. Some of these immune complexes become deposited in the walls of small blood vessels or the alveoli of the lungs. The immune complexes activate complement and initiate an inflammatory response that damages the tissue, impairing its physiological function. When antibodies or other proteins derived from non-human animal species are given therapeutically to patients, type 3 hypersensitivity reactions are a potential side effect. Small immune complexes are less efficient at fixing complement, and they tend to circulate in the blood and become deposited in blood vessel walls. When these complexes accumulate at such sites, they become capable of fixing complement and initiating tissue-damaging inflammatory reactions through their reactions with the Fc receptors and complement receptors on circulating leukocytes. This type of reaction is called an Arthus reaction. This stimulates mast cells to release histamine, causing urticaria, and recruit inflammatory cells into the tissue. Platelets accumulate around the site of immune complex deposition, and the clots that they form cause the blood vessels to burst, producing hemorrhage or erythema in the skin. Arthur's reactions usually appear as localized areas of erythema and heart swelling or induration that subside within a day. Serum sickness is an example of systemic type 3 hypersensitivity reaction, which injected animal-driven antibodies to treat diphtheria, scarlet fever, tetanus, and other life-threatening bacterial infections, were recognized as an antigen by host antibody and resulted in deposition of small immune complexes in tissues. This condition occurred some 7 to 10 days after the administration, which resulted in chills, fevers, rash, arthritis, vasculitis, and sometimes glomerulonephritis, depending on which tissues are affected. Therapeutic administration of serum from other animal is rarely used today, except for antivenom antisera for neutralizing the effects of snakebite. Serum sickness may occur occasionally in patients who have a myocardial infarction and are treated with the bacterial enzyme streptokinase to degrade their blood clots. IV administration of large amount of penicillin may also trigger serum sickness. All effects of serum sickness are transient and resolve once the foreign antigen has been cleared by host antibody. Well, as time goes by, old problems resolve and new problems arise. Finally, moving on to type 4 hypersensitivity. The effector molecules initiating type 1, 2, and 3 hypersensitivity reactions are all antibodies. In contrast, type 4 hypersensitivity reactions are caused by the product of an antigen-specific effector T cells. Most reactions are caused by CD4-Th1 cells. For example, the inflammatory reaction around the site of an insect bite or sting is caused by CD4-Th1 cells that respond to peptide epitopes derived from venom and other insect proteins introduced by the bite. This is called delayed type hypersensitivity reactions because they occur 1 to 3 days after contact with antigen. The amount of antigen required to elicit a type 4 hypersensitivity reaction is 100 to 1,000 times greater than that required to produce antibody-mediated hypersensitivity reactions. This difference reflects the intrinsic efficiency in generating peptide epitopes from protein antigens for presentation by HLA molecules. Example of this reaction is the tuberculin test. The inflammatory response is mediated by Th1 cells that recognize peptides derived from the M. tuberculosis protein that are presented by HLA class II molecules, stimulating tuberculin-specific memory T cells in a tissue, generating effector Th1 cells locally. Then it initiates further inflammatory reactions that recruit fluid, proteins, and other leukocytes to the site. A minority of type 4 hypersensitivity reactions are due to cytotoxic CD8 T cells. They arise when small reactive lipid-soluble molecules pass through cell membranes and bond covalently to intracellular human proteins. Degradation of these chemically modified proteins yields abnormal peptides that bind to HLA class I molecules and stimulate cytotoxic T-cell response. For example, the allergic response to poison ivy involves cytotoxic T-cells. These recognize peptides derived from intracellular proteins that are modified by chemical reaction with pentadecacatechol, a chemical acquired by touching a plant's leaves. This is what the hand will look like after touching these plants. And these are the blisters formed. Patch test also relies on type 4 hypersensitivity to detect possible allergen, most of them being metals. If the patient is not allergic to the molecule, the skin will show no change. However, if the patient is allergic to the molecule, then it will present local erythema or minor swelling. And in these areas, you can see the changes. Well, that's all about hypersensitivity. Type 2 hypersensitivity reactions are mediated by IgG antibodies directed against cell surface or matrix antigens and are commonly caused by medications. These medications bind to surface proteins of erythrocytes or platelets, creating new epitopes that stimulate an antibody response. Type 3 hypersensitivity reactions are caused by soluble immune complexes formed by IgG binding to the soluble antigens against which they were made. This can occur when non-human proteins are given therapeutically and the host react to this by producing antibodies towards these proteins. Type 4 hypersensitivity reactions are caused by effector T cells often responding to reactive chemicals transferred into the skin by physical contact to cause a contact dermatitis. So, if you'd like to know about hypersensitivity more in depth, then in this era of internet, as Einstein would say, just Google it. Thank you for listening to my presentation.